And the repartee between Dr. Mahipal and Dr. Bharti has already taken care of what I had to say. Anyway, nevertheless, I'll continue and reiterate those facts. I'll be talking on corneas at risk for laser refractive correction, primarily LASIK. So, as we know, LASIK has revolutionized refractive surgery and was believed to be the panacea for everyone and anyone wanting to be rid of glasses. However, it's been a little over 2 decades, 21 years since LASIK came in, and we are much wiser now and realize the limitations of LASIK. And the biggest bugbear, or whatever causes nightmare to most refractive surgeons, is the corneal ectasia that may occasionally follow LASIK. So it's imperative to identify corneas at risk for laser refractive procedures. Various devices and technologies have come in, and they aid us in detecting corneas at risk. However, please remember there's no magic formula or specific topography that can tell us that it is safe to go ahead with in a certain patient. It requires careful evaluation of the patient and a deep understanding of topography and various other parameters, which I'll be alluding to a little later. So in terms of risk factors, certain factors have been identified. However, there's no absolute sure shot parameter available. Certain risk factors have been identified, and some of them are still controversial, as we saw the debate a little earlier. There is a technology limitation, although there's been quite literally a blast in technology and now we're picking up a lot of cases, so that the incidence has gone down from 1 in 2,500 to almost what is estimated as 1 in 4,000. But still, we are not able to pick up all potential cases of ectasia. And very importantly, as Dr. Mahipal said, from a medico-legal standpoint, it is important to know these risk factors and to take precaution, because you have to, if faced with such a situation, it is important to show that the current standard of care was followed and your decisions were supported by evidence-based medicine and peer-reviewed literature. I mentioned the incidents here. So a lot of work has been done by certain workers. The first such ectasia score system was proposed by Randleman. It has come into a lot of flack, but we'll go into that. But some of the risk factors that have been identified are abnormal topography, which is the most important. It could be a frank keratoconus, form first keratoconus, or any other ectatic corneal disorder. Residual bed stromal thickness is another, which again is linked to the total pre-op pachymetry. So there's no magic number here, but most surgeons, initially it started with 200 microns of residual bed, then went on to 250. Most of us now prefer to be somewhere around 300, 270 to 280 is what is a viable Viamid. But yes, as Dr. Bharti said, many eyes below this level, below 250, because there was a time when 200 was being left, are still doing well. But then the flip side is many eyes with a residual bed of 350, 400, 370 microns also have developed ectasia. So yeah, that's true that the thickness is not everything. There are other factors involved, but this is one of the factors. Then there are certain other risk factors like younger patients. Randleman et al. Put a lot of emphasis on younger patients, but again, this has been criticized. And the logic here is that if you do earlier, maybe the form frustae has not got time enough to manifest. Asymmetry between the two eyes in terms of topography or refraction, enhancement should generally be avoided, and higher refractive errors, of course, predispose more. So this is the ectasia risk score system. This was the first one which came out, still stands valid today, although there are better ways of doing it also. So essentially you see here there are various parameters, 5 parameters over here, and the scoring system is from 0 to 4. So the limit of the scale could be from 0 to 19. So in the topography pattern, for a score of 4, you have form frustae or any other abnormal topography, 3 with inferior steepening or skewed radial axis, and asymmetric bow tie gives you 1, and normal or symmetric bow tie gives you 0. Then the bed thickness, again, more than 300 is 0, and it progressively increases. Age, now this particular scoring system put a lot of weightage on age, which has been criticized over the time, because supposing all the parameters are 0 except for age, then and you operate upon 18, we started 18 to 21, then you would straight away go to category 3, and all the other parameters being 0, and you would end up with moderate risk. Now if you look here, a score of 0 to 2 means it's low risk, you can proceed with LASIK or surface ablation. A score of 3 means moderate risk, which recommendation is proceed with caution, consider special informed consent, and safety of surface ablation has not been established. Now this is the important line I want to emphasize here, because generally what we say is, okay, there's a little doubtful topography, let's do surface ablation. If the cornea is abnormal, surface ablation is not going to save you. It's just, it's a false sense of security. It's better to avoid any refractive procedure in such a patient. But anyway, going strictly by this criteria, it could be very much skewed. So as a result, this this was the first statistically validated structured approach to the problem of ectasia, but has come under criticism because tends to screen out more patients, overemphasizes the age of patient, and moreover, this did not have elevation topography like the pentacam or OBSCAN. It was based on anterior curvature analysis also, which we now know is not the most reliable form of topography for refractive surgery. And it also just took one central ultrasound reading. In contrast, pentacam nowadays with the Bellin-Ambrose display and examines the pachymetry across the entire breadth of the cornea. However, it's a good starting point for screening in patients, but needs further refinement. So the basic trends that are being followed now are minimum pachymetry of at least 490 to 500 microns, varying towards 5 to 510 microns, and residual stromal bed thickness of at least 270 to 280 microns, more towards 300. That would be ideal. And a maximum ablation of 130 to 140 microns. In fact, Dr. Amrish is going on to 120 with a LASIK extra. The asterisk marked ones are the ones which the Ministry of Health guidelines. Most of us are not aware the Ministry of Health has issued certain guidelines, and the ones marked in asterisk are the figures mentioned there. So be wary of enhancements, because apparent regression may actually be early ectasia. And shifting to surface ablation in suspicious topography is not really a very good idea. Other viable options are now available, like phakic IOLs. Cross-linking with surface ablation in suspicious topography is something what I call a relative wariness, because now this still needs to be validated. I know a lot of people on the dais and the faculty are doing it, but please remember these are people who are very experienced cornea and refractive surgeons. So this cannot be the take-home message that everyone should start doing it. It still needs to be validated, but may be a promising modality in the future. In conclusion, detecting corneas at risk for laser refractive surgery is still not an exact science. Therefore, surgeons have a greater responsibility to understand the corneal topography well, follow laid down guidelines, not to fool around with them, because then you can land up in trouble. A lot of surgery, a lot of cases, medical legal cases are coming up. Avoid temptation, which I understand can get very difficult in the absence of absolute criteria, because it may be a little something maybe in the topography, but with a good corneal thickness of about 580, 590, 600 microns, you may be tempted to go ahead. Or the corneal thickness is about 500, but the topography is perfect, then again you may be tempted. So these extremes we need to be cautious. Be safe, err on the side of caution. Elevation-based topography systems fare better. They evaluate the posterior surface and the pachymetric change across the cornea, and techniques or devices analyzing biomechanical properties of cornea are likely to play a greater role in future to prevent ectasia likelihood. Do I have a minute or so? I can just give a sort of a very brief overview of. Okay. Now, the idea is elevation for refractive surgery. This is not keratoconus per se, managing keratoconus. For refractive surgery, elevation topography is the ideal. Nowadays, of the lot, Scheimpflug-based topography is the one that we really go for. Of these, the most prevalent system is the pentacam. Some of the things that one can look for in pentacam is what I would like to highlight here. Now, if you see just 5-6 points, because everyone, I've often been asked this question, how do we look at it? Just look at the quality check here. First thing that it says okay over here. It's not a blink or something. So if this is fine, then you look at these values over here. These are the keratometry values. And then look at these maps. This is the sagittal curvature map. This is the front elevation, the back elevation, the pachymetric map. You have to see the front and the back elevation, see the float diameter. I'm talking about a 9 millimeter float, where the thinnest point should be at least 15 microns on the front and 20 microns. So here you see it's 9 and 4. So this means this is a good map. Then you come to the Bellin-Ambrose display, where these two should actually be green. I'm giving you a very sort of a synopsis. So there's a lot more depth and detail, but that'll take a long time. So these should be green, and these boxes here should be white. And this graph should be between these. They should not be cutting down or dipping down. So this, in short, is what you need to look for. So in contrast, if you see here, you can see this. I said it should be 20 maximum on the posterior float. It's 55. It should be 15. It's in this case, it's 30 over here. So this is suspicious. You go ahead, see the Bellin-Ambrose display. It's not green. It's red. So it's like a traffic signal. If it's green, go ahead. Yellow, be cautious. Red means don't go. Don't do the surgery. And these boxes also are not white. There's some yellow, some red. So this was just to give you a brief idea of what pentacam is. So at least you can have a quick view before going on to your cornea or refractive colleagues. Thank you for a patient hearing.
Thank you very much, Dr. Ashu. We have panelists Dr. Narang and Dr. Khanna. I don't think Vivek Pal is there. Dr. Narang, you wish to make any comment? Sorry?
Ashu, the comparable to the posterior float in OpScan, which is we take 55 as the cutoff. What is the comparable this thing on the pentacam?
Yeah, okay. The difference between OpScan and OpScan has certain red flags. I didn't have time, so I didn't talk about
I
it.
mean,
Yeah,
just
so the
what
thing
is comparable in the pentacam?
Here you see the anterior and the posterior float. Now it depends on the OpScan does not allow you to vary the float diameter. Here you can vary the float. So 9 millimeter float, I said on the posterior surface the thinnest point should be 20 microns, and on the anterior surface it should be 15 microns. On the 8 millimeter float, which is another very commonly used thing, it's 8 microns on the anterior and 16 on the posterior, which is suspicious.
One observation, the government of India rules, as he mentions every time.
He always likes to be on the right side of the law, which is fine, which is good.
I want to mention, it says 18 or above.
Yeah.
And 1 year
Stable refraction.
stable refraction for at least a year.
Yeah, and 140 microns maximum ablation,
Yeah.
490 microns
So you
minimum
think
corneal
that
thickness.
anybody who is, yeah? Okay. What I said was that the law says that
It's not a
18
law.
or
It's not
above.
a
It's
law,
not a
it's
law.
Minister
It's
of
a
Guidelines.
It's
recommendation.
not even a guideline.
It's
It's a
a-
committee which
it's a-
met and
Yeah.
made that. That's
So
all.
Subsequent to the controversial,
recommendation from the health ministry says 18 or above, stable refraction for 1 year. So you think that everybody who is doing, according to Randleman's criteria, everybody is doing a LASIK at 19, 20 is having, giving a risk factor of say 3,
Yeah,
number
so-
3 for all the patients. And also, I personally feel that the Caucasian eyes behave, differently than our, eyes. So either we should have our own criteria to, match that kind of study as to how many patients we did who were 18 or 19 and developed with other criteria remaining stable. How many of them develop kind of ectatic conditions after LASIK? Or otherwise, I think we should take it with a pinch of salt that, because we cannot, kind of ignore the social reasons why these ladies want to get their and then not do it till the age of 21.
So actually during the presentation, if you noticed, I mentioned that age has been overemphasized. This has been a criticism against this study. This came out in 2003 for the first time, and subsequently Dr. Perez Binder and Stulting, Perez Binder, they came out with their own data and said that this was overestimating.
So
Now the point is, certain conditions don't allow certain countries don't allow refractive surgery below 21 years of age. That's also another fact. So although in India we do it at 18, again there's no guideline, we're doing it. The thing is, yes, this study, this criteria overemphasizes. The reason I put it up was that it serves as a good starting point to know. And I also mentioned if you start, all the parameters give a score of 0, cumulative score of 0, but you do a 18-year-old, you straight away go to a moderate risk of 3, the score of 3. So yes, age is one thing we can discount, but yeah, the logic here is the minimums have been given. 18 is the lower side of the age, 490 is the lower side of corneal thickness, and 140 residual bed of 250 is what is accepted, but we are all veering towards 300, 270 to 80. So that is the idea, because these are not carved in stone. These are figures that haven't come as commandments from the gods. This is something that you have to just evolve over with time.
Thank you. Yeah.
Yeah. 25% of the total thickness, that means for a 550 micron cornea, you won't go, or a 500 micron, you will.
It's 125 now.
125.
So basically the point.
It's the same thing.
It does not translate to the same because you're upping the upper limit. So if you have a 600 cornea, you would go to 150.
Yeah, but
that doesn't.
That doesn't translate. 140 is still, 130 is still the upper limit. Yeah.
See, because it's not just the question of ectasia. I think I don't know. I would consider myself also to be a referral center or something like that. The incidence of ectasia is really not great. If in a month I see ectasias from post LASIK, I don't know, my other colleagues might bear me out, but I think we see about 3 to 4 eyes a month, maybe not more than that. I don't know what you are seeing. So I don't know. Rohit? Huh? Less than that, okay. Anybody else who is seeing more than 3 to 4 eyes of ectasia per month being referred?
Doubt it.
Doubt. So I think
Post LASIK. Post LASIK. Ectasia is
नहीं
always post
दूसरा ectasia तो
वो तो
keratoconus तो I am talking of post LASIK. See, basically, I think that's the real. I think Khokar left. RP Center would be another referral. Dr. Goel, you are hardly seeing. Okay. Yeah. So one case in a year. 6 months. So basically, anybody from PGI? No. So I think that's the number of LASIK units have been substantial over the last couple of years in Delhi. So the incidence of ectasia is really not that, but I think these things are just to keep you on the safer limit. The only thing is that whatever are your parameters that you are setting,